Today's module is actually combined for two specific wrist and hand problems, Quervain's Tenosynovitis, and I'll put that in English in a moment, and trigger finger. I put them together because they can be sometimes confused, although they should not be, and because they're not so common in my practice that they would merit, I'd say, an individual module for each. Quervain's Tenosynovitis, sometimes simply called DQT, involves inflammation of the tendon sheath of the first dorsal compartment. You'll recall from your anatomy this compartment involves APL, abductor pollicis longus, and extensor pollicis brevis. Putting that in English, those are tendons that allow the thumb to extend, basically. And you can get an inflammation of that tendon sheath, which can be terribly painful. And I'll talk about specific exam maneuvers that you can use to distinguish this from other hand and wrist problems. Trigger finger is often more straightforward to diagnose, and literally patients will talk about their finger being stuck in flexion, for example, and they have to straighten it out, for example, when they wake up in the morning. And I'll talk about specific physical exam maneuvers as well for making that diagnosis and how you might distinguish that from some of the other common hand and wrist problems we encounter in our practice. Okay, so for Quervain's Tenosynovitis, I'll call it DQT to make our lives easier. And for trigger finger, the focus again is on the hand and the wrist. These are injuries that typically come gradually over time. Occasionally they can be acute from trauma, but not as often. And I'm lumping them together because they're both hand problems that are fairly common. I always do a more proximal screening. I actually screen the neck and the shoulder. Not as important here, but I still believe that sometimes you think somebody has something here and in fact it's a radiating problem from the neck area. Also, you can look at some of the biomechanics. So for example, if patients have really weak scapular strength, so when we test serratus anterior, they're weak, or the external rotators, it will put increased stress on distal structures such as the hand and wrist muscles. So as you think of your treatment plan, you often start working on posture and strengthening of the scapular muscles in order to treat more distal problems in the hand and wrist. For DQT, the classic finding, it's a tenosynovitis. It's an inflammation of the tendon sheath of the first dorsal compartment. And that's, you can palpate it just about where the wrist is. You can feel it just about there, just a little bit away from the snuff box. Bring your thumb up, hold it straight up as hard. That's the anatomic snuff box people have heard about from their medical school days. And the first dorsal compartment is just a little bit towards the front or volar to the snuff box. It's two tendons. If you feel carefully, you'll feel a little bump of two tendons. One is abductor pollicis longus, and the other is extensor pollicis brevis. And pain will typically occur when the patient tries to bring their thumb up. Worse if I try to resist. The classic finding, there'll be tenderness there at the first dorsal compartment, and the so-called Finkelstein test. You have the patient hold their thumb like that, and you do that, and they're not happy. That causes an extra pull and pain on that first dorsal compartment. Often helps clinch the diagnosis, but in your differential diagnosis, you're thinking also of basilar joint arthritis, which I discuss in another module. You're thinking of a more generalized tendinitis that you might see with a cumulative trauma disorder. For trigger finger, typically the patients give the history of the finger getting stuck and they have to manually open it. The classic finding is the A1 pulley area, where the flexor tendons go through, will be focally tender. So you press there by the A1 pulley, and they'll have a focal tenderness and not elsewhere. They don't typically present with triggering to you because it happens at various times of the day, but you do want to be wary. For example, if they present with a slightly flexed finger like this and they think, well, I think it's triggering, doc, you can try to figure out, is that something that's really from a tendon or from intrinsic tightness of the joint itself? And the so-called Bonnell test can help us with that. And the Bonnell test is, let's say the patient presents with a little bit of flexion here at the PIP joint. The Bonnell test, what it does is if you vary the tendon length by bringing the metacarpal joint into flexion and extension, if it's a tendon tightness, it'll actually go like this. It'll actually flex the joint more. because as you bring this into extension, you're actually putting more stretch on the flexor tendon in the front of the finger. On the other hand, if it's intrinsic tightness to the PIP joint, say from a fibrotic process or post-trauma, it'll actually not vary as you alter MCP, range of motion. So again, basic biomechanics. Okay, that you use your basic biomechanics to help distinguish between what might be intrinsic to a joint or what might be of flexor tightness. Treatment for both of these may involve injections, if not improving with more conservative treatments such as hand therapy. Injections have typically been with cortisone. We tend to use PRP in our clinic, which is showing more and more promise. We often use ultrasound guidance, but I think probably some surgeons feel like they don't need that. And if patients are not improving, they would go for surgical release. Generally a pretty mild surgery to my understanding.